So I just want to welcome Dr. Jeffrey Neal. He is a PEM physician at Boston Children's Hospital and assistant professor there, and is also the Associate Director of Ultrasound and Director of Ultrasound Education. And has published quite a bit on ultrasound guided LPs, and that is what he's here to talk about today. So thank you so much.
Hi, everyone. Thank you for having me. Let me just see if I can I have to request share. All right. Can you guys see that? Perfect. Okay. So today I'm going to talk about ultrasound and pediatric LP. And I understand that this is a group of pediatric hospitalists. I'm curious in terms of who does the LPs if LPs need to happen on the floor, because there's been a slight change at Boston Children's Hospital recently, but how does that all work for you guys at Yale?
For us, it's usually the hospitalist.
Okay.
Um, yeah, I mean, if it hasn't happened in the ED, then it'll be the hospitalist.
Okay, great. And so what I'd like to talk about first is just a little bit about background around LP, previous research that has looked into factors contributing to pediatric LP success. And then we're going to show a brief video on ultrasound assistance and how you can mark on infants all the way up to your older adolescent patients. And then I'll talk a little bit about the study that I did in residency while I was at CHOP, as well as some additional studies that have recently come out on ultrasound assistance in LP, and a meta-analysis that sort of grouped all these studies together and gives a final conclusion. And please feel free to stop me along the way, ask any questions. I won't be monitoring the chat, but if you guys can let me know if there's any questions that pop up, I'm happy to answer them.
I can monitor the chat for you.
Great. So what we know in general is that rates of unsuccessful lumbar puncture in infants are quite high. The inability to obtain CSF or obtaining a traumatic tap, it can be as high as 50 to 60% in the literature. And the recent ACGME changes in terms of the amount of times that residents spend in the pediatric ER, as well as their exposure to procedures, is decreasing. And that's twofold because of those ACGME changes, but also because of the AAP guidelines that have decreased the amount of LPs that we are doing. When I moved to Boston from Philly, they were still doing taps for 0 to 90 days. And now, obviously, we've sort of decreased down to only 0 to 28 days. And so the exposure for residents is very low. A couple of studies that were in the literature, Schreiner et al. Said 50% resulted in repeated attempts or traumatic taps. And Pinheiro said only about 45% were successful on first attempt. Um, David Kessler also looked at whether just-in-time training made an effect. So there was a cohort of pediatric residents in cohort A. They were sort of had this standardized LP teaching and simulation. And then in cohort B, there's this concept known as just-in-time training, where you sort of go over the procedure right before it's about to happen. And that was considered the intervention group. And really, there was no difference in terms of clinical success rate. 35 to 38%. Again, pretty terrible. Why are successful lumbar punctures important? I think most people understand generally, if we are able to get a successful lumbar puncture on infants that are older than the 21 to 28 day group, then you can send them home. And so a study done at Boston Children's about 10, 11 years ago looked at the difference between a normal LP that was obtained versus a traumatic or unsuccessful LP. And they showed higher rates of hospitalization in the traumatic group. Obviously, because it's hard for you to make a determination if there's meningitis or not. Some people feel comfortable doing that red blood cell to white blood cell correction. But if you have a certain amount of white blood cells where you're just uncomfortable making that decision, you have to admit until you have the culture negative after 24 to 48 hours. And they also looked at hospitalization costs, and the hospitalization costs were much higher. I think the median hospitalization for infants with traumatic LPs was about $5,000 higher. Factors contributing to success. So these are sort of things that have been borne out in the literature for infant LP. Uh, how many people do lateral decubitus versus sitting position?
I've never tried sitting.
Never tried sitting. Yeah. And
Yeah.
do you guys use the infant small tap? No. So I don't know if anyone has sort of seen
Yeah, and then some people in the chat are saying some do it lateral, some sitting, trying to do sitting if the infant can tolerate it.
Yeah. I think there's someone on not on mute. Just FYI. Yeah, so the infant small tap sort of this like the miniature torture device. I personally don't prefer it, but we have it in the ER at Children's in Boston, and it sort of straps them in this to the sitting position, and with a little bit of sweetie. Sometimes they'll even fall asleep, is what I've heard. But I still prefer the lateral decubitus. But there is some evidence to say that the sitting position is beneficial in terms of getting a successful LP. Patient age, obviously, so the smaller size of the patients can be difficult. So over the age of 12 weeks, your odds of getting a successful LP is higher by threefold. Use of local anesthetic, so whether that be a topical anesthetic or an injectable, your odds ratio is about twofold higher. And then early stylet removal. So this is known as the Cincinnati method. We'll talk a little bit more about this, but for infants less than 12 weeks, the thought of taking the stylet out once you've gone below the dermis allows you to see the flow of CSF a little bit easier, since there's not that traditional pop from the ligamentum flavum that you get with older patients. And then other factors that show no significant difference. So provider level, whether it be from an intern to an attending, and then family member presence during the procedure. I personally always ask the parents to sort of step out, because I think it's just difficult for them to see their kid go through such a slightly painful and barbaric procedure. But there is no difference. An attending here, Lise Ningervik, showed there was no difference if the family member was present in the room in terms of your success. So the Cincinnati method, this is called the early stylet known as the early stylet removal. Basically, you have the spinal needle advanced until it's below the epidermis and then dermis. You stabilize the needle, remove the stylet, and then essentially you can advance until you see that CSF flow. And I found great success with that, and try to teach that to all of our trainees and PAs. So in terms of ultrasound assistance, first reported in the Russian literature back in 1971. Again, there's sort of several different studies that have looked at what we can use it for. There was one study that basically said you were able to identify the intervertebral level a little bit better. It was more successful than palpation. You correctly identified it with ultrasound at about 71% versus 30% in palpation. And that's likely exacerbated in infants given the small intervertebral spaces. It can also help identify the presence of a tethered cord or an epidural hematoma. So this is where I tend to use it the most, is if I've had a kid come from another hospital where they failed about 3 or 4 times, taking a look to see if there's any hyperechoic blood that's collected above the subarachnoid space. And then it's helpful in specific adult patients, particularly the obese population. And it can often disclose the reason for a failed LP, whether or not there's a decreased amount of fluid within the subarachnoid space, if there's an epidural hematoma. And overall, we know that it's easy to use and simple to learn. There's one study in 2007 that said high quality images were obtained in less than 1 minute in 90% of scans, and in less than 5 minutes in 100% of scans. So it really doesn't add too much when you think about your procedure prep, getting everyone in the room, a clinical assistant to help hold the patient, your consent. It really only adds a couple of minutes of time. Data on the effect of the reason we sort of thought about doing this study was, the data on the effect of bedside ultrasound and the success rate of infant LP was pretty limited. And we saw such a high failure rate with traditional methods that we were trying to think about ways that we could improve our success. And before our study, which was in like 2014 to 2016, there were 2 randomized controlled trials in the adult literature Nomura et al., which really only looked at about 50 patients that were randomized to either traditional palpation or ultrasound. And they found that the ease of the procedure was better with ultrasound versus palpation, but no statistical difference in terms of the number of attempts, traumatic LP, or procedure length. And then Peterson et al. Was also looking at about 100 patients with 50 in each study group. And they also found no significant difference between those undergoing ultrasound localization and those with palpation alone.
And then there's just one comment in the chat that with the amount of repeat LP attempts that many hospitalists are tasked with doing and the very common incidence of post LP hematomas, the Cincinnati method would be likely to get repeat blood rather than doing active guidance with stylet removal in the CSF pocket past hematoma.
Yeah, so I think traditionally, and I have a picture of this later, at least what's done in our institution is if we fail an LP, sometimes we'll get admitted off antibiotics if they look well. And then we'll undergo, ultrasound guidance to look at whether or not there's a pocket of CSF there in terms of their ability to then do the LP without getting that blood return. So this, I hope, will work. And please let me know if you can't hear this, but this is a better way of explaining how the ultrasound LP marking is done. And we'll just sort of, it's a 2-minute video, but I think it will give you a better idea of sort of how the ultrasound LP is done.
To begin, position the patient as they will be during the actual procedure. It is typically easier to position neonates in the lateral decubitus position, but larger infants can be positioned upright. Utilize an assistant to keep the patient in position with the gluteal fold in line with the spinous processes, and keep the hips, knees, and the spine of the patient all flexed. For the ultrasound, you will want to utilize your machine's high-frequency linear probe. Pay attention to the depth markings of your probe. You should need no more than 3 to 5 centimeters of total depth to visualize all the structures in question. Adjust the depth on your machine to get a good view of the entire spine. In this image, we can identify several things. The hyperechoic structures closest to the probe are the spinous processes, creating shadows. The deep hyperechoic structures are the vertebral bodies. This hyperechoic stripe is the dura, and just outside of that is the epidural space. Here is the subarachnoid or intrathecal space containing black hypoechoic cerebrospinal fluid. In this next image, we will see the termination of the spinal cord, or the conus medullaris. Just distal to the conus, you can see the strands of the cauda equina. Note that you can actually see the termination of the spinal cord, so you know not to puncture cephalad to this. This is another image showing a small pocket of CSF with the spinal cord lying deeper. Learn to use landmarks along with your imaging to improve success. Ultrasound is particularly helpful because you can see the depth at which you should enter through the dura and arachnoid mater, and also how deep you can go before you get beyond the intrathecal space. Here we see we should expect to be entering the subarachnoid space at a depth of about 1.3 centimeters to the skin. The actual depth of available CSF for this inner space is 1.2 centimeters, and if we have gone beyond 2.5 centimeters to the skin, we will not be able to obtain any fluid. Remember or write down these depths as you are performing the puncture. Knowing this will help limit the amount of needle movement, thus decreasing chances of a traumatic or unsuccessful tap. Documentation on the skin is a personal preference, but we recommend you first center the image over a desirable inner space. Centering the image is an important step. Next, place markings on both sides of your linear probe. Rotate the probe directly over that inner space 90 degrees. Ensure again that the axial image of the cord is centered on the screen, and then make markings on both sides of the probe. When you are finished, you will have a target to insert your needle. You can also make marks for another inner space if you desire. After the skin has been marked, the ultrasound gel can be removed and the back can be prepped over your markings.
So that's just a great example of how the ultrasound markings are done. I personally have found the depth is super helpful. And it's pretty amazing how much you can actually see with infants. The bones aren't as mineralized, so there's not as much shadowing with ultrasound. And you can really see the depth that you need to go to get to the subarachnoid space, the depth that's too far before you hit a venous plexus, and that ends up the reason why we tend to get a lot of traumatic taps. And so it just provides you with a lot of information, and the marking is quite easy. People always ask, will the betadine, iodine, will that take away the markings? With our skin markers, they stay, and it works quite well. And so this is, kind of the way that you would typically do a static marking. So now I'm just going to talk about our study that we did in Children's Hospital of Philadelphia. It was entitled The Effect of Bedside Ultrasonographic Skin Marking on Infant LP Success. And basically, again, the hypothesis was that bedside ultrasound assistance will lead to a significant increase in the proportion of successful infant LPs by frontline clinicians in our pediatric ED. So our primary goal was to determine the effect of bedside assistance on the proportion of first attempt LP success, and then overall LP success, which we defined within 3 attempts. It was a prospective randomized controlled trial over a course of 18 months. We calculated a sample size of about 128 patients. There were 2 main study ultrasonographers, myself and Aaron Chen, who's still at CHOP as the director of ultrasound there in the emergency department. And it was at CHOP. Inclusion criteria: less than 6 months of age. The plan for a diagnostic or therapeutic LP, we had to have availability of myself or Aaron. Luckily, at that time, I did not have children, and I was about a 5 to 10 minute walk to the hospital, so it was pretty easy to get there. And the exclusion criteria was a known spinal cord abnormality, like a tethered cord, and non-English speaking patients. We did a computerized block randomization, and we randomized in either the traditional LP arm or the ultrasound-assisted LP arm. And as you could see, and as you saw in the video, you can visualize the spinous processes, as well as the conus medullaris, and then the subarachnoid space here. And what we typically did for each patient in the ultrasound LP arm was we marked the best sort of pocket of fluid below the conus with the cross marking, and then we marked the termination of the conus as well, just so folks would know that they could not go beyond that spot. And then their first attempt had to be at the marking of the cross. Again, these are the images that you typically will obtain. So in the transverse view, you can see an axial image of the subarachnoid space. You can typically see the hyperechoic spinous process to mark. And then in the longitudinal view, you're able to see each of the spinous processes and then be able to measure the depth down to the subarachnoid space. And then again, we would sort of center this on the screen and then mark that spot. Here's an example again of the conus. Super easy to see, as you can also see the cauda equina fibers. And you can typically see this up to about 6 to 12 months of age before the bony shadowing and the depth makes it a little bit more difficult. Here's a quick video. Again, spinous processes. And as you can see, as you go more distal and caudal, it tends to get a little bit smaller in terms of your pocket of fluid. And so we would tend to mark what we thought was the largest space that was safe and below the conus. This is an example of a video in the transverse view. And as you can see the transverse processes on the side. And then you can see the subarachnoid space again with the cauda equina fibers at the bottom here. So this is the reason why we tend to get traumatic taps, right? So these are a Doppler view of the veins and the plexus that surrounds the subarachnoid space. And so, if you go too far, you risk puncturing one of these vessels, and that's how we get a traumatic tap. So if you're off the midline, if you're too deep, and this is one of the benefits I do think that's helpful in terms of using ultrasound to know what your maximal depth is. Again, just an example here of the plexus and just the images. So I always make sure my trainees know that, take that stylet out, go slow, try to stay in the midline so that you can not have that traumatic tap. So we defined LP success as obtainment of CSF, and then based on previous definitions of traumatic taps, we ultimately concluded on red blood cells less than 1,000, as you know, that would be unlikely to make any significant effect on the number of white blood cells in the tap. And this is our overall, one sec. This is our overall picture here. So in the traditional arm, we had 64 patients. In the ultrasound-assisted arm, we had 64 patients. And when you look at it overall, there was an absolute risk reduction with the ultrasound-assisted arm in terms of less traumatic taps for first attempt success less than 1,000, within 3 attempts less than 1,000, as well as less than 10,000 as well. And so there's different sort of risk reductions, but they were all significant, and they decreased the overall median overall attempts from 2 attempts to 1. Any questions about the study? Okay. So I'm just going to go through a couple of other literature that's out there in terms of again, additional studies that have been done. So
And
this was,
someone just had a quick question about if you have a needle gauge preference.
yeah, I mean, we tend to use like the 1.5 inch, I believe it's 22 gauge, if I remember correctly. But we use, you know, whatever comes in the kit, and I usually grab 1 or 2 more of the 1.5 inch 22 gauge needles.
And then the other question was the ultrasound component in the study was just the static marking, right? Where was there dynamic
No, yeah.
use of
So,
ultrasound?
yeah, essentially, again, was that picture back a couple slides back. We would mark, the patient would be in the position. We would go in before the procedure was done. We would mark with the cross the space that the provider would have to go at, as well as marking of the conus. But then the ultrasound part was done. And we also looked at the total amount of time that added, and it was anywhere from like 1 to 3 minutes prior to the procedure. Um, you know, people have always asked about dynamic ultrasound guidance. I personally think that would be quite difficult. You know, the amount of hands that you would need, sterile probe. You know, the infant patients are not sitting still. In an older patient, it would certainly be a little bit more possible, but I think in an infant population, the ability to have someone that's holding the patient still while you're a sterile, you know, you'd probably be a dual provider process in terms of being able to have someone manipulate the ultrasound for you. So I think that'd probably be a little bit more difficult. All right, some newer studies that have come out. So this is entitled "A Prospective Investigation of a Novel Ultrasound-Assisted Lumbar Puncture Technique on Infants in the PDE ED." This was a smaller sample size, but looked at, again, ultrasound-assisted LP versus standard palpation landmarks. And they had 20 in the ultrasound group and 15 successful in the standard group, with a few more that were unsuccessful overall in the standard LP group. And they define success as less than 10,000. So these are the typical thresholds that you'll see. But the ultrasound LP group, they actually had 95% success as opposed to the standard LP group, which is 68% success. And that was significant. And then in terms of obtainment of CSF, which is the ultimate goal, right? And I think that is sort of clearing of any traumatic blood, but that was successful as well. They looked at the stylet out technique. It was interesting that you know, more sort of used the stylet out technique in the ultrasound assisted group, but they found no statistically significant difference. And the odds ratios for success for ultrasound LP was 9.3, but pretty wide confidence intervals, assuming the smaller sample size. And the number needed to treat, we looked at this as well. You know, for every 4 patients that have ultrasound LP would lead to 1 increased success. So I think, you know, pretty good for a number needed to treat. We had similar numbers as well. Another study looked at this as well. So pre-procedural ultrasound for infant LP was a randomized trial. Similar sort of setup. Again, looking at the primary outcome of CSF obtained on first attempt with less than 1,000 red blood cells. They actually found no statistically significant difference between the groups. Similar failure rates, 50%, 45%. When looking at CSF obtained on any attempt, slightly higher in the ultrasound assisted group, but not approaching statistical significance. And then overall CSF attainment on any attempt, again, no statistically significant difference. So this was one of the one of the negative studies that was shown out there. Another study, this is emergency physician performed ultrasound assisted lumbar puncture, another randomized controlled trial, 166 patients with 84 in the ultrasound assisted group and 82 in the standard group. They had a total of 23 physicians performing ultrasound, which is much higher than our study. But again, I think it speaks to the ease of this procedure. It's very easy to see the landmarks and be able to identify them. And the proportion of successful first attempt LP was higher in the ultrasound group, about 68%. But less so than the standard group, and this failed to reach any statistical significance. The difference was only 8.1%, but crossed zero. This was the study, I believe, that was done out of South Carolina. We actually just had a recent ultrasound conference down in Charleston, and I met the person who had done this study. But this looked at a comparison of ultrasound marked versus standard LP success in infants. They looked at the success in a group of retrospective infant LPs, and then a prospective ultrasound marked group, which they obtained about 74 patients. And they actually broke it down by medical student versus PGY level versus fellow versus PA versus attending. And this again is sort of, when you look at the overall success rate here, again, I forget what they defined. Oh yeah, less than 1,000 red blood cells. This is why provider level doesn't tend to matter. So the attendings, 4 out of 10 were successful in the retrospective traditional group, which I think is pretty low. But there was no statistically significant difference, between the success rates in the retrospective traditional group. And then when you look at that compared to ultrasound marked group, again, none of these reached statistical significance, although they were higher overall for most of the higher level folks. They didn't approach statistical significance.
In the other studies that you presented, do we know the makeup of if they were included trainees or were just the attendings?
Yeah, so I think most of them record that. We recorded it as well. And at CHOP, it's really much more resident driven in terms of procedures as opposed to fellow driven, because the fellows there end up precepting at such an early stage in their career. And so I think we had a higher proportion of residents doing the procedure, but the provider did not make any effect on the overall success rate. So this was this was my fellowship project that I did at Boston Children's. This was a project that we looked at the variability of preferred infant lumbar puncture insertion site between more novice and experienced physicians. The thought process here was that, trainees tend to go lower, right? I feel like everyone has this anecdotal experience where if a trainee fails, you're like, I'm just going to go one spot higher. And so we wanted to see if that actually bore out when we looked at it on a research side. And so what we did is what would happen is we would consent the patient, the trainee would go in, and they would mark with an invisible pen where they would do the LP based on palpation. And then the attending would go in afterwards and mark with a visible pen. And then I'd go in and be able to identify where the trainee had marked. And then we looked with ultrasound, was there a difference in terms of the subarachnoid space and the space that they marked? And overall, we found that trainee and attending LP interspace markings were concordant in about 27% of cases, but that overall the trainees marked a preferred interspace below the level of the attending in 55%. And within those, 28% were in one spot, 20% were 2 spots, and about 7% were actually 3 spots inferior in relation to the attending. So I think overall, this kind of proved again that trainees tend to mark a little bit lower, more caudal than those marked by the attendings. And when you look at it under ultrasound, that subarachnoid space is actually quite small. So this was one of the more pronounced differences in the subarachnoid space. So the top is where the attending had marked. And then you look at the subarachnoid space here in the CSF pocket versus where the trainee had marked. This was like almost a bone marrow biopsy. but there's really not much there that they're able to get at. So again, this just sort of proves a little bit more that, if you can go higher, and with ultrasound, you can mark the highest level that you can go because you can look at the conus.
And then question in the chat about what are the strategies and outcomes that you've seen when there's no visible CSF pocket?
Yeah, so again, when I tend to use ultrasound more is when there's failed LPs. So if we get an infant that's transferred, usually from like a community adult hospital, where they've attempted a couple of times. This is a perfect way into this picture here. But I tend to do ultrasound, and if I see the picture that's on the left, where there's a minimal CSF pocket, then I'm like, there's probably no chance of us even having success, and so I'll just admit the patient, wait for some of that epidural hematoma to accumulate, and then lean on interventional radiology to help us out in the next day or two to get the CSF. So this ultrasound here, if you look at the picture on the left, marked A, the black arrows mark a hyperechoic sort of area of blood in the epidural space, which is an epidural hematoma. And as you can see, the white arrows, that's really the only amount of CSF that you're able to obtain. And then this white asterisk marks the conus, and the black asterisk marks the cauda equina. And so there's really pretty minimal fluid for you to go after. And your chance of success is going to be quite low. And this was 48 hours later after IV hydration. That epidural hematoma is still there, but there's, again, a larger pocket of CSF that once you get through, you can take off to sample for cell counts and culture. So overall, this is the ultrasound-assisted lumbar puncture meta-analysis. This was done, I think, a few years ago, and this was an updated amount. But it includes all of the major studies that we talked about and a few more, with pretty large sample sizes, except for this one that was done in 2015. But again, pretty large sample sizes, and then they look at the transducer type, the mean age of patients. So there were some that were primarily infants, but some that were done in an older population, and then the sonographer experience, which was mainly attendings with occasional residents and fellows. And then so looking at the risk difference overall, they look at all the studies and then do a total amount. So less than 1,000, less than 10,000, and there was some favoring of ultrasound, except for less than 10,000. And then also risk difference here, looking at this was traumatic LP, regardless of the definition used, and according to the red blood cell threshold, there was a slight risk reduction for ultrasound overall in terms of reducing the traumatic depths. So their conclusion from this meta-analysis was that POCUS improved the first attempt success rate and reduced the incidence of traumatic LPs compared with the standard LP procedure in children, regardless of the definition used. So I just wanted to kind of open this up now to say kind of what do you guys do, and when do you use ultrasound-guided LP? I can speak a little bit to like how I've used it in my practice. I feel pretty good about my overall success rate with infant LP. But when I'm working with trainees, sometimes I'll bring the ultrasound in just to show them how easy it is to see where the conus is and where the landmarks are. And then certainly if there's a failed infant LP from another hospital is when I tend to use it a little bit more. And looking for an epidural hematoma and making sure there's a pocket of fluid that we can go after. And then I have used it with success, for patients where we're worried about IIH and there's obese or overweight. I think just using it to be able to at least mark a spot, you can use it to mark the midline as well as mark an intervertebral space. Being able to see the conus is a little bit more difficult, but that's where you kind of weigh on your palpation landmarks. So has anyone here used ultrasound for static landmarkings?
Two people said they have and that they
Yeah,
like it.
yeah. and so I think overall it can provide a little bit of extra guidance, particularly for, you guys if there's been, I mean, if there's not as much success that's done in the emergency room, do you guys have interventional radiology do it, or who does it for you if it's failed in the ER?
For us, it's usually either interventional radiology or neuroradiology, but they also frequently ask us to repeat it on the floor before
Okay.
they'll also try to. And then, yeah, a lot of people in the chat are saying IR. And then, yeah, and then that they're also asked to repeat as hospitalists before
Yeah.
IR.
Yeah. Yeah. I
Yeah,
mean,
as
it's
hospitalists, I feel like most of the time we're doing repeat attempts from ICU, outside hospital, ED. And so um, ultrasounding initially, I mean, I think there was some study that showed whether the LP was successful, traumatic, or not. The incidence of hematoma in infants is like a third of patients.
yeah. Yeah. It's fairly high. Yeah. Yeah, I mean, I think it's unfortunate, right? Like, with the AAP guideline changes, now you could avoid an LP if you're 22 days or above. And so the exposure and the practice for the pediatric residents is, I can't imagine. I think it's less than 5 for most pediatric residents, probably less than 3. And the experience is going to continue to decrease. Our success rates are probably going to stay the same, if not get worse. And so, anyway, you can sort of increase your success and decrease hospitalization rates, unnecessary antibiotic use, I think is beneficial. So that's all I have. Here's our references that we kind of talked about. And here's my email. If you guys have any questions, please feel free to email me. I'm also happy to answer any more questions that you guys have right now.
I'm curious if you know of any successful training models out there.
It's interesting. We have a trainee sort of like sim model, infant model, where you can practice LP on. And I run the pediatric POCUS elective with a colleague of mine who we've combined this year to do procedures and POCUS together. And he does a lot of just-in-time training with pediatric residents on LP, and you can practice the actual LP procedure as opposed to ultrasound. I'm not positive, but I would encourage you, if you want to get some practice, pull any infant patient that's sort of hanging out there and take a look with an ultrasound, because it's quite easy, and it's quite quick too, and it's painless. So if parents are willing and it's not too busy of a shift, you can probably bring it into the room and just take a look.
Hi, this is Andrea Mato, hospitalist over at CHLA. Thanks for this talk. It was really great to have the overview. We've actually had some success with DIY training models using ballistic gel and just like a spine model from Amazon or online, pediatric spine model, and it's not perfect. And I think one of the things that we're working on is trying to see if we can figure out a way of modeling the actual neonatal landmarks, so the CONUS and all of that. So still working on that, but I think there are definitely, and even on online, like on ZU and some other websites, there are some tips and tricks for how to build them. So I can put that in the chat if that's helpful for people. I guess one pitfall that I've run into, so I now try to do ultrasound markings for all patients, big and small. And I think in older patients, what I have found is that a pitfall is if you place your markings not in the exact position that you are going to actually perform the lumbar puncture, the skin shifts a lot. And so we found, if the hips are not perfectly aligned when you're doing the ultrasound, and then you're crunching them to get a bigger CSF space, or you're aligning the hips a little bit better, there's a huge discrepancy between where you marked and where the midline is. And so I guess I don't know if anybody else has run into this difficulty, but would just encourage to make sure that the positioning is like optimized before, because I don't think you think about that. You're like, oh, I'm just gonna look and then I'm gonna actually like make the patient sterile and get them into the perfect position. But it really does matter, positioning even before starting your sterile procedure.
Yeah, 100% agree. I mean, I think when we tend to do it for the older patients, they can sit still a little bit easier than the infants. Um, but typically we'll bring it in and do it in the position that they're going to do the LP and then quickly do the procedure right after. But it's a good point that the skin can move quite a lot.
I'm, hey, Matt Yoakum from UCSF. I'm mid peds. I do a lot of adult and large patients, and I always bring the ultrasound probe in because even in older patients, they move, especially if you're talking about large patients and you're doing marking. It just needs to be in there. My personal feeling on it. Infants, it might be easier to see the midline, but yeah, I, it doesn't take that much longer to bring the probe in if you have, something that can be across the bed from you.
Yeah, I think also in the adult patients, I have had some success if you use a high frequency linear probe or a curvilinear probe and you go off the midline, a little like a oblique view, you can actually see the upper level of the subarachnoid space and get a sense of the depth as well. So I've used that before to know sort of what needle I need to bring in because some of those older patients you bring in like the 4 or 5 inch needle.
Yeah, if you're doing that in bigger patients, and we just had something out this last year, the anterior complex, you can focus on that because if you're we didn't talk about there, but if your ultrasound can see the other side of the spinal canal, then your needles can see the other side of the spinal canal, even if you can't see a CSF pocket like you can in infants.
Yeah.
Hey, Dr. Neal, thanks for this great talk. I had a question about how you approach training like other attending colleagues. Like I have the issue of being the only one who does this at my institution, and a lot of residents are eager to learn, but I don't have the bandwidth to teach everybody. And so I guess have you found successful approaches in approaching like other colleagues to teach them and get them engaged in this technique? Like there's definitely interest there, but I've had trouble like consistently getting people to learn it and do it in practice. They're always too nervous and then they come back to me again. And so, but I struggle.
Yeah. No, it's a good point. I think we struggle enough. We have a pretty large attending group of about 50 or 60 attendings, plus about 10 to 20 more in the community. I think we struggle even with basic credentialing for like soft tissue, fast, and cardiac lung. Um, we have a super supportive chief who started the last couple of years and has really tried to pump up ultrasound and has given us the opportunity to schedule scanning shifts as part of our clinical time, which is great. And so we have instituted amongst our division of 4 ultrasound attendings these 4 hour scanning shift blocks where attendings can sign up for 1 to 2 hours and come and literally just scan with us without worrying about clinical patients. And so that's been super supportive and allows us to teach both the basic credentialing applications, but sometimes even more of the non-credentialed LP markings, appendicitis scans. And so I think if you can get support from, you know, higher ups in your division to give you some extra time, that's usually where I find it to be beneficial because on shift or if you guys, while you're in the hospital, it can be quite busy and finding the time to do ultrasound training and or teaching is difficult.
Do you have many instances? I've kind of found here that sometimes if we have a handful, we don't have as many, med peds people here that do ultrasound, but if we have a handful of people that know how to do it, then can save and send images securely, because we're tasked, as you noted, with doing a lot of repeat LPs. So if, even if they don't necessarily know what a spinal hematoma looks like exactly, they're able to get the images and send them to us. Do you find that that's been a strategy that's worked for any of y'all?
So I'm not sure I understand the question. You have community sites that like send you ultrasound images?
No, no, no. Our colleagues
Oh
who may
yeah.
not know as much ultrasound, you know.
Yeah. Yeah, I mean, we do a lot of our image review on like a weekly basis. So I've certainly had people contact me when I'm not in the hospital, and be like, "Hey, can you look at this ultrasound real quick?" But yeah, I mean, we always give sort of feedback when we can. If we're in the ED, we can help people review it. Uh, but yeah, I think overall, it's really just the time spent and the experience of scanning that will help people sort of improve their comfort with doing these types of scans.
And then there's a question about if anybody bills for this.
Yeah, we will tend to bill for, I don't know if we've started to bill for this, but we bill for, most of our standard credentialed applications. We bill for procedural IVs. Um, but it's a good thing to bring up. Actually, I don't know if we billed for nerve blocks, but we haven't billed for ultrasound LP, to my knowledge.
It's Kevin. Brian, we bill in South Carolina, but the interesting part is if you're doing intensive care for neonates, it's bundled, so you can't. So something to think about depending if you are doing neonatal sepsis and you're billing higher, or if kids are in the ICU or a step down, it's typically bundled care. But there are CPT code modifiers you can do for ultrasound assisted or guided LPs.
What images do you obtain when you bill, Kevin?
We do exactly the images he showed, longitudinal and sagittal, and we document both and send them through. So
You just need an image of the anatomy. You don't have to have like one with the needle in there or anything.
yeah.
So you could do it if you weren't going to bring the probe onto the field. I just to echo what Dr. Yoakum said earlier, I always bring the probe onto the field and just have it there available because people move around and kids especially are a little wiggly sometimes.
All right. Any more questions for Dr. Neal?
I had a question about with the sort of the research that you've done already with LP, what do you think might be some like future areas of research with ultrasound assisted LP that, either in the ED or in the hospital that you think could help to kind of move the field forward?
That's a good question. I mean, I think there's been enough studies looking at the ultrasound assisted marking. I think for older patients, the dynamic ability potentially could be helpful. But I think it's really just the experience, and I think people tend to feel that bringing the ultrasound in is just a little bit more cumbersome for them. But I think for the older patients, having a dynamic procedure could be beneficial because I don't know how you guys feel, but for some of the obese patients, it's kind of, just luck that sometimes you get there. So,
Yeah.
Yeah, I think the one worry, there's a couple of anesthesia articles there, and we came from a place where we had to do like in the adult world all active guided like paracenteses. And when you follow the needle deeper and deeper, it becomes increasingly difficult versus lining everything up with where you need to go. And I think the anesthesia literature that's out there, if you're talking about dynamic for older images, isn't all that impressive. It seems like they have to do a lot of poking around to get where they need to go. I mean, they always get to where they need to go because that's typically what anesthesia does, but
yeah.
it the pass rates don't look especially exciting to me. So it take a lot of experience, I think that's the other worry, like as hospitalists, I don't know, might vary, but there might be value in a few champions. We just don't, I don't know, maybe other places get more LPs, but it's a bit more limited than say in the ED.
Yeah, I feel like I've done 2 in the last 6 months, maybe. It feels a lot less than during residency.
Yeah. Yeah. It's probably going to get even lower. There probably is going to be some biomarker at some point where you don't need to do an LP anymore. There was actually an ultrasound paper that had come out. I don't know if you guys saw this, looking at AI enhanced images of the spinal canal and being able to look at white blood cells without even doing an LP to predict bacterial meningitis or not. And so they sort of had looked at like some AI enhanced images of, those longitudinal views of the spinal canal, and they could somehow see the number of white blood cells and be able to predict with pretty good specificity whether or not there was bacterial meningitis or not. So that's certainly coming down the pipe as well.
That's amazing.
Yeah.
Wow.
Well, again, thank you guys so much for having me. I really appreciate it. And thanks for all the engagement and questions. And my email's there if there's any more things that come up.
Thank you so much, Dr. Neal. We really appreciate your time.
Take care.
Thank you. And this recording will be uploaded to our YouTube channel. So if you guys want to revisit it, it'll be there for you.
Thanks for setting it up, Lubina.
Yeah, they're good turnout.
Yeah. Yeah, there's a lot of people. All right. We'll see ya.
Bye.